Good morning, student. In this video, we will discuss about the pulmonary surfactant and its clinical importance. At the end of this session, you will be able to list the composition and functions of lung surfactant. You will be able to explain pathophysiology of clinical diseases associated with surfactant deficiency as well as surfactant excess. Now, this is a known curve that I have already discussed in the previous video. You can see that in the left hand side, it is a compliance curve. It is also known as the compliance curve or the pressure volume change curve. So from this curve, it is you can see that the curve has inspiratory and expiratory components, and you should note that inspiratory and expiratory compliance curves, they do not coincide. There is a gap in between them, which is this difference is called hysteresis. Now what is compliance? Compliance is the slope of this curve, that is delta V by delta P. Unit change of the volume change for unit change of pressure is known as the compliance, which indicates the stretchability or distensibility of the lung. Now lung volume at any given pressure, you can say that take the pressure of -10. So the volume at -10 in the inspiration, and if you compare it with that deflation curve, you can see that at any point at any given pressure, the greater lung volume will see in during the expiration than the inspiration. Okay, so another important point we can note from here, the pressure, the compliance is greatest, the stretchability is greatest at the mid pressure range, and at the high pressure range the compliance is lowest because the curve has become flattened. Okay, so on the right hand side you can see that another important point you can see here, if the lung is inflated by normal saline, then this difference between the inspiration and expiration, it is obliterated. Okay, so there is no hysteresis in saline with the saline inflation, but in air inflated lung hysteresis is seen. Why? Because we must know here that when the lung or alveoli is trying to expand, there are some forces that oppose this expansion, distensibility or compliance. The two important and major forces are, one is the elastic recoiling force of the lung tissue itself, another is the opposing force caused by the surface tension. So here in the saline filled lung, as it is filled with water, okay, so there is no surface tension, because surface tension, how it is created in the alveoli, inside the alveoli there is a thin layer of fluid which creates an air water interface, which gives a major contribution to the surface tension. Okay, so if we fill the alveoli with the saline, this air water interface will be not present, then there will be no hysteresis. So from this we can conclude that these both opposing forces, as the elastic recoiling and the surface tension, among them surface tension is a major force, it is a major opposing force for the lung distension. So now what is surface tension? Actually the force that pulls the surface molecule together. From your knowledge of physics, you know that the force that pulls the surface molecules together of a liquid at an air liquid interface is called the surface tension. From the left hand picture you can see that there is a fluid lining inside the lung, and this fluid lining is actually creating air water interface, and that is creating the surface tension, because at the air liquid or air water interface of alveoli, water molecules are strongly attracted to one another than to air molecules, and the surface tension in the air liquid interface in the lung alveoli is the major factor that influences lung compliance. In fact, it accounts for more than half of the elastic recoiling of the lungs. And what is the function of this surfactant? Surfactant, then it prevents the distensibility or the compliance, so it favors the collapse of the alveoli. Now the surface tension in the air liquid interface in the lung is a major factor that we know, and it is a factor that helps or favors the collapse of alveoli. Now in the lung, actually the inner lining of the alveoli, in order to reduce the surface tension, we have a special chemical that is known as the pulmonary surfactant. The surfactant means a surface active agent that decreases surface tension. Now, pulmonary surfactant, from the left hand side picture you can see, is a thin liquid film present at the alveolar lining that decreases the surface tension at this gas liquid interface of the alveoli. And how it actually alters the surface tension we will see later. First, see the what is the structure and composition of this pulmonary surfactant. Pulmonary surfactant is a mixture of lipoprotein rich in phospholipid. The principal surface tension lowering agent here is the dipalmitoyl phosphatidyl or DPPC. Dipalmitoyl phosphatidyl or DPPC. Now, phospholipids or surfactant has a hydrophilic head, you can see here, and a hydrophobic tail. The hydrophobic tail consists of fatty acids, and the tail it faces towards the alveolar lumen. The alveolar surface tension is inversely proportional to the concentration of phospholipids in the surfactant. More the phospholipid, that means there will be less the surface tension. Now, other than dipalmitoyl phosphatidylcholine or DPPC or dipalmitoyl lecithin, it is 62%. Other than that, some other phospholipids are present. Phosphatidylglycerol 5%, other phospholipids 10%, and some neutral lipids are also present, that is 13%. Okay, and it also contains the lipids. It also contains proteins, that is 8% proteins, albumin, immunoglobulin A, and the surfactant protein A, B, C, D. It also contains the carbohydrates, that is 2% of carbohydrate is also present. Now, how actually its synthesis happens? The palmitate, choline and glucose are substrate molecules for surfactant synthesis. The substrate molecules are taken up by alveolar type 2 cells from the circulating blood. We know that there are two types of cells in the alveolar epithelium, type 1 and type 2 cell. Type 2 cells are metabolically more active and contain more number of mitochondria, and they have a special histological feature that they have the electron dense lamellar inclusion bodies or lamellar body. We can see here these type 2 pneumocytes containing the lamellar bodies. Now, actually, what is present inside the lamellar body? In the mitochondria of these type 2 pneumocytic cells, after they uptake this palmitate, choline and glucose, they will synthesize the DPPC. Then the surfactant will be stored in the lamellar inclusion bodies, and the lamellar inclusion bodies are continuously discharged into the alveolar surface by constitutive exocytosis. What is constitutive? Because this exocytosis, it is continuous and it is unregulated. Now, the released lamellar body materials, they will be converted into tubular myelin that forms the film of surfactant on the alveolar surface. Okay, and the active synthesis of lipid in the lung accounts for the high rate of replacement of surfactant. Thus, an integrated layer of surfactants is continuously formed in the alveolar epithelium. Some amount of surfactant is recycled or reuptake by the type 2. Now, these are the steps in the flow chart you can see. So, first is the DPPC substrate molecule. They are synthesized in the mitochondria, and protein component is formed in the endoplasmic reticulum. Now, DPPC and proteins, they are packaged in the Golgi apparatus. Materials will be stored in the lamellar bodies. Lamellar bodies from type 2 pneumocytes are discharged towards the surface of the alveolar epithelium by constitutive exocytosis, and lamellar bodies are converted into tubular fluid, that is tubular myelin. Tubular myelin forms a phospholipid film of surfactant on alveolar epithelial cells. So, this is the way of synthesis. Now, come to the regulating factors. There are mostly 5 regulating factors. First is the hormonal factor, then are some pharmacological agents, exercise, and then also some role of protein is also there for the synthesis of uh, surfactant, and the stretching of lungs. So, these are the 5 factors: hormonal, quantity, quality of protein, stretching of lungs, pharmacological agents, and exercise. So first is a hormonal factor. Glucocorticoid is most important. We will see that at the during the term when the mother is about to deliver the baby, the glucocorticoid synthesis is increased and its receptors in the lungs it also increases. It helps in the maturity of the fetal lung. In addition to glucocorticoid, thyroxine also helps or promotes the surfactant synthesis, and insulin, it also facilitates the surfactant synthesis. That is the reason why in case of gestational diabetes, that is if the mother is having diabetes during pregnancy, that will decrease the surfactant secretion, and these children they are at prone to develop some diseases related to deficiency of surfactant. Now, quantity and quality of proteins in the surfactant, it is also important. There are 4 types of surfactant proteins, A, B, C, D. Among them, A actually controls the reuptake. And also, what is the role of these proteins? These proteins actually help the phospholipid film to be um, stretched uniformly inside the inside the alveolar lining. Okay, the protein content depends on the concentration of protein in the plasma. Now, stretching of lung, it also helps the surfactant synthesis. Yawning and shining during infancy, they are very effective stimuli for surfactant synthesis. So, pharmacological agents like beta adrenergic agonists, they will enhance the surfactant secretion, and the calcium also stimulates surfactant secretion. Exercise, practice of regular physical exercise, it stimulates the surfactant synthesis both in children and adults. Now, the functions of surfactant, it prevents the lung collapse, it promotes the alveolar stability, it helps to prevent edema in the lung. Surfactant decreases the work of breathing so that breathing becomes easier. It has roles on the immunity. As we have seen that SPA, we also have the immunoglobulin A in the surfactant protein. Okay, but in this video we will more focus on the first point, that is how the surfactant it prevents the collapse of lung. Now, the surface tension, how it is lowered by the surfactant, that can be explained by the Laplace's law. The Laplace's law states that the pressure in a spherical structure is equal to twice the wall tension divided by the radius, that is P is equal to 2T by R. Okay, where P is the pressure required to keep the spherical structure patent, T is the surface tension, R is the radius. And from this picture, it is obvious that if the radius is greater, then the pressure required to keep it patent is lesser. So it is P is equal to 50 on the left hand side. When the radius it reduces by half the reduce, the pressure required to keep it patent, it becomes doubled. So we can say that the smaller alveoli, all the alveoli do not have the same diameter. The alveolar sizes also changes during inspiration and expiration. So when we are expiring, the alveoli are becoming smaller and smaller. So if we keep the surface tension same in all alveoli, so according to law of Laplace, pressure would be greater in the smaller alveoli. They will collapse and they will as they are interconnected with the larger distending alveoli, so they will collapse, okay, especially at the low lung volumes. But so the smaller alveoli will join with the larger alveoli and they will collapse, but it does not happen in the normal cases, as because of the presence of surfactant, which keeps the surface tension constant per unit surface area, that is around 59 per centimeter square. How it is keeping? Because when the alveoli it is becoming smaller and smaller, we can see that and in this picture you can see that the density of surfactant molecule per unit surface area, it is lesser in case of the larger alveoli, but density of surfactant per unit area, it is more in the smaller alveoli. So in that case we can say that if P is equal to 2T by R, when R is less, so T will also be reduced by increase in density of surfactant per unit area, that will keep the surface tension constant. This is the reason why the smaller alveoli are not collapsed in while we are expiring or in smaller lung volumes. So by this law of Laplace we can explain it. Now, deficiency diseases of surfactants. So the most important clinical disease related to this surfactant deficiency is the infant respiratory distress syndrome, or IRDS. It is also known as the hyaline membrane disease, or HMD. It happens when a baby's lungs are not fully developed and cannot provide enough oxygen, causing breathing difficulties. You can see that the baby is having tachypnea, tachycardia, and most importantly cyanosis, grunting, chest wall, we can see the chest wall recesses. Okay, so the baby will be cyanosed and will die. It usually mostly affects the premature babies, and IRDS usually occurs when the baby's lungs do not have the enough surfactant, and baby normally begins producing the surfactant from the 24 to 28 weeks of pregnancy. So before that, if the baby is delivered, in case of premature baby, so the deficiency of surfactant will be more. Okay, so why this disease is also called as the hyaline membrane disease? Because there will be formation of necrotic eosinophilic hyaline membrane lining in the alveoli, and alternating atelectasis and dilatation of alveoli you can see in this histological picture. So necrotic eosinophilic hyaline membrane lining in the alveoli, will be there. That is the reason why it is called the hyaline membrane disease. Now the surface tension of these babies, it will be very high. So the alveoli are collapsed in many areas. This collapsed alveoli, it is known as the atelectasis. We know that when the baby first cries, that means that it is taking the oxygen and it is taking the air and lung is inflated. This inflation will be very difficult in these babies. Okay, now some addition other than surfactant deficiency, additional factors are also responsible. During fetal life, some amount of Cl minus ion, chloride ion, is secreted with the fluid by the pulmonary epithelial cells. When the child is born, what happens? The epithelial sodium channels at the layer of alveoli, they become activated, and they absorbs these epithelial sodium channels. They absorbs the sodium, and along with sodium it absorbs the fluid. So in case of premature baby, these epithelial sodium channels will also be immature, and they cannot absorb the sodium and the fluid, so that will also prevent the expansion of the alveoli. You can see on the right hand side, the lung, there is no air, it is totally white. Okay, so this is the atelectic lung of the IRDS babies. Now why how can we diagnose this case? The maturity of lung, if the premature delivery is required, if the mother is having premature onset of labor. So for this we must know how this surfactant is generated. At the 24 weeks gestation, type 2 cell lamellar bodies appear. Then at the 32 weeks of gestation, sphingomyelin level, it decreases, and lecithin level increases in the surfactant. And the 34 weeks of gestation, surfactant is secreted by the fetus. Okay, so for the assessment of the lung maturity, we can do these 5 tests. One is the lecithin sphingomyelin ratio, second is the shake test, third is the saturated phosphatidylcholine in surfactant, fourth is the lamellar body count, and fifth is the fluorescence polarization. So if the lecithin sphingomyelin ratio, if it is more than equal to 2, then it indicates the lung maturity. From this figure you can see the death associated with RDS. RDS means respiratory distress syndrome. If it is 100%, if the LS ratio is less than 1, but if it is 2.6 to 3, then the death is 0. Okay, so respiratory distress syndrome related deaths, it will happen in immature lung, and lecithin sphingomyelin ratio, it should be more than equal to 2. That indicates the lung maturity. Now second test is the shake test. It is also called the bubble test or the Clemens test. In this test, what we do, the amniotic fluid is mixed with 96% ethanol and it is shaken for 15 seconds, and then it will be kept and inspected after 15 minutes. If there is presence of bubbles, that indicates maturity of the fetal lungs. Now if the test is done on serial dilutions of amniotic fluid, one can calculate it foam stability index. Okay, if the foam stability index is more than 47, so this is a foam stability index. It measures how long these bubbles it takes for the foam height to drop by half. So if the FSI it is more than 46, 47, it excludes the risk of respiratory distress syndrome. Then the third test is the saturated phosphatidylcholine in surfactant level. If we measure, if it is more than 500 nanogram per ml, it indicates the lung maturity. So saturated phosphatidylcholine, that we have to measure. Okay, so one is the lecithin sphingomyelin ratio, second was the shake test that will show the bubble, third is this saturated phosphatidylcholine in surfactant. Now fourth test, that is a screening test and very cost effective, is the lamellar body count. We know that in the lamellar body is the storehouse of all these surfactants. So lamellar body count, if it is more than 30,000 per microliter, it indicates the lung maturity. Another test is the fluorescence polarization test. Now presence of 55 milligram surfactant per gram of albumin, it indicates the fetal lung maturity. So for us, what we do actually, it is a very popular method. Okay, the ratio of surfactant albumin it is determined in the amniotic fluid. Okay, so unique fluorescent probe, that is binds to both albumin and phospholipid. Okay, so we will evaluate the level of the surfactant in relation to the amount of albumin. If per gram of albumin, in the per gram of albumin, if 55 milligram of surfactant is found, then it indicates that lung is matured. So what about the treatment of these cases? First is the administration of betamethasone. That is, we know that glucocorticoid helps in lung mature. If we see that mother is going to premature labor, so the mother, we can give the mother 2 doses of intramuscular betamethasone 24 hours apart, especially before 34 weeks. Then the surfactant replacement therapy we can give. The endogenous surfactant preparation is now available, that is the Survanta. It is given within 15 minutes of birth in very premature infants by direct tracheal instillation through a feeding tube. On the right hand side you can see that. And the dose of Survanta is 4 ml per kg body weight. Okay, so you can see it has reduced the infant mortality significantly. After 3 hours you can see that how much air has entered into the lung. So this is Survanta, and it contains, it's 25 milligram per ml. Okay, so 4 ml means it is 100 milligram per kg of phospholipid. So there are certain diseases which are congenital deficiency of surfactant. One is the SFTPC gene mutations can be there. There may be, in that case, the accumulation of AEC2 Golgi and endoplasmic reticulum. Okay, and there will be activation of intracellular stress signaling. Another is that ABCA3 loss of function, that will actually cause the impaired phospholipid trafficking, and SFTPB mutations, it is very common in case of congenital surfactant deficiency. So there will be abnormal surfactant composition and function, and NKX21.1 gene mutation, there will be reduced surfactant protein BC, and all of them are, they will cause the lung parenchymal inflammation and interstitial lung diseases. Now we have discussed about the deficiency of surfactant. Another disease is there where there will be excess of surfactant, that is known as pulmonary alveolar proteinosis. So what happens? It is an autoimmune disease, and there will be reduced surfactant clearance. Surfactant production is okay, but it is not cleared, because for clearing the surfactant we require GM-CSF, that is granulocyte macrophage stimulating factors. So the auto antibody, it will be, that is IgG, will be developed against this GM-CSF. So GM-CSF function will not be there, and there will be reduced surfactant clearance. Males are predominantly affected at the age group of 30 to 50 years, and histologically it will be characterized by presence of periodic acid skip positive lipoproteinaceous material in the alveolar airways. So diagnosis is done by elevated serum anti-GM-CSF titer, and treatment is done by whole lung lavage through a double lumen endotracheal tube. So here we can see the presence of these acids give positive lipoproteinaceous material in the alveolar airways, and on the left hand side, the upper picture shows the presence of autoantibodies against this GM-CSF. On the right hand side we can see the picture of the lung where there is excess of surfactant and air entry is prevented. So we have the learning objectives that you will be able to list the composition and the functions of lung surfactant, and you will be able to explain the pathophysiology of diseases in surfactant deficiency and excess. I think it has been done. So these are the references. Thank you.